This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, May 20, 2024. I'm Len Sierra. I'll be moderating today, as I always say, with a little help from my fellow moderators and all the attendees here. Firstly, we want to acknowledge and thank our sponsors, and they are Bayer, Johnson & Johnson, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And with no further ado, we will go to Paul Frieda. Go ahead, Paul.
Okay. Thanks for giving me this top spot. I have to go pick up family at the airport pretty soon, so I'm glad you let me in first. Let's see. I guess I could start. 10 years ago, I had a prostatectomy. It was pretty successful, but it didn't get everything. When I came out of a few months later, I had a PSA of 0.224, and Dr. Walsh's book said that you're probably metastatic if you're not, when you come out of prostatectomy with that. So I went on Lupron, 3 months, every 3 months got a shot. And after 3 years, the doctor and I decided we'd try to go on a holiday. And so we stopped the Lupron, and I got 5 years of remission. PSA stayed undetectable for 5 years until early this year, and came in at 0.13. Then it went to 0.17, so finally I had a little trouble getting the PSMA PET scan, but finally got through insurance and had it. And it showed a spot near the bladder, and so my medical oncologist had me see a radonc at a proton therapy facility at Delray Beach Medical Center, and I sat and talked to him for a long time, and he had a lot of comments. I was expecting him to be enthusiastic and say, okay, we'll give you your treatments, and you can start on Wednesday or something like that. But he said that a number of things. One of the things he said is that it's possible it was a false positive, that spot, and he said it was located near one of the staples that was left in after my prostatectomy, and it was very close to the bladder. And he admitted to me that when they radiate, they would be radiating part of the bladder for some reason. Not intentionally. I just think that the bladder, he couldn't guarantee that the bladder wouldn't get hit. And that was my major concern. I don't want to add problems to my cancer. And so he said that maybe we should do an MRI and get a more accurate look at it. And so that's how I left it with him. And then today I saw my medical oncologist that I've been seeing for 10 years. And he said something different. He said that he thought that because of all of the uncertainty and the doubts, that I might be better off. Oh, okay. One thing I left out is that my PSA went to 0.3 went from 0.13 to 0.17. Then it went back to 0.15, and then it went to 0.3, and that was 6 weeks ago. And then just recently I had it. Another PSA was 0.3. It hadn't moved in 6 weeks. And so for that reason, my med-onc said, I think maybe we should just wait for another month or two and see what it does. And if necessary, and then we can pick one of the drugs and see if we can, well, he was very confident that it would put it down. But what he did say to me that was very surprising, he said that probably after 9 months or a year, you'll probably be able to get another remission. I didn't expect him to say that. In other words, if I went on one of the drugs after 9 months or a year, we'd stop the drugs, and he predicted that I would get 1 to 3 years of additional remission. So I'm not exactly sure which what I want to do, whether I want to do the MRI and take a closer look, or whether I want to just do what the med-onc suggested. So that's where I stand right now.
Paul, what do you have to lose by doing an MRI? What do you have to lose by doing an MRI?
Good question. Good question. I guess I'm really reluctant to do the radiation. It's like 40. You're sitting for 40 days, and when I was on the Lupron for those 5 years, I tolerated it really well. I had a little bad neuropathy for about 9 months, and I'd have to get out of bed and stretch my leg because it would tighten up. But I'm sort of leaning that I like the drugs more than the radiation. So, but you're right. There isn't much to lose of doing the MRI. You're right.
Yeah, I kind of like Jack's advice there. And also, when you're facing that much radiation, if it were me, I'd be like you, Paul. I'd say I'll take my chances with the drug, see if I get a nice long remission. By the way, what was your Gleason score?
My Gleason was the Gleason coming out of surgery was 4.4, but my initial diagnosis was 3.4. Then I gave them the slides before the operation, and the people at Memorial Sloan Kettering said I was 4.3, and then of course coming out of the surgery they had me at 4.4, and so
4.4 is definitive, Paul. Doesn't matter what they said before. 4.4 is definitive because they take the whole prostate, they slice it up, they see everything, and they come out. So don't even worry about what they said before. You can't get a better Gleason score than your post-radical prostatectomy.
Yeah, the pathology report, virtually everything was negative except that it did get out of the sac. I had negative margins, negative seminal vesicle, negative what do you call lymph nodes. So it was, a lot of it was very positive, but it did get out. And now the reason I think I had 0.224 looking back on it is my prostate was 5 times larger than most people's prostate. And as you probably know, normal prostate cells put out PSA, just not as much as cancer cells. So that might have been the reason that I was high, but that certainly doesn't explain why it's come back now. So some of it got out somewhere, and that's it. So I have a decision to make, and I have to say I was very impressed with the doctor at the proton therapy unit. It's a separate building, beautiful facility next to Delray Beach Medical Center, and he was very honest, and I was very impressed with him. Young guy. His name was Jim Snyder. So,
Paul, what was the reason he wanted to do an MRI? What was he looking for?
Well, because one of the reasons I wanted to do it is he mentioned things like it could be a false positive. He wanted to get a closer look. He feels the MRI gives him a more detailed look than the PET scan, and so that was it. But there's so many things negative that the radiation is going to get to the bladder. He didn't think it was something that would be too much to worry about, but I'm not real happy about that. And the drugs certainly will. Well, my med-onc is absolutely certain the drugs will put it down, and so I have to think about what I want to do. I want to think about it for a few days. But any input anybody has, I'd be happy to hear it.
So it sounds like you've never had anything beyond what we would call locally advanced prostate cancer, right? Anything you had was beyond the capsule, but still in the pelvic region. Is that correct?
Yeah, that's right. That's right. We have no indication.
You're very likely to continue to do very well on hormone therapy, just as you did the first time around.
Yeah, that's the way my med-onc feels about it. And so, like I say, the idea of 40 treatments radiating the whole area there for one small spot if it were, well isolated and it was clear that it was going to grow, then I'd go for the radiation. But because of his uncertainty about a number of things, I'm reluctant to do it. So
Yeah.
So he's
that's
talking about 40 treatment proton
40 treatments. Yeah, 40 treatments.
So
I think it's 360 degrees around you.
So it's not pencil beam proton focused on the spot.
No, I think it is. It's supposed to be. It should be a well-controlled beam. Yeah. I asked him how are you going to hit it? How are you going to know you hit it? He says, well, we have X-rays. We take X-rays and we put you into a mold, and that hopefully will hold you. But then again, keeping my body, within a millimeter is, a little bit unrealistic to me. So that's there's just a lot of things about it that makes me uneasy. But I actually was impressed the fact that a radiation oncologist was not jumping, had me jump into radiation. Another radiation oncologist might have just tried to talk me into it, so I'm very happy that he was very honest with me.
Yeah, I mean, as I stated, if it were me, I would go with the drugs rather than radiation. But on the other hand, keep in mind that for bladder cancer, they often do radiate the bladder. So, I mean, it's not the worst thing in the world. If they go after a lesion that's right next to the bladder and they may hit the bladder a little bit, it doesn't mean, you might have some urinary urgency, some burning, things like that, but it's unlikely that you would be incontinent as a result of something like that.
Well, he said there might be a side effect as a result of hitting the bladder, but he felt that it would go away, within a month or two. So, like I say, he was very honest about it, and I did appreciate that. Beautiful, like I say, a beautiful facility, really beautiful facility.
Oh, we've got some hands up. Joe Commanda, go ahead.
Yeah, I don't want to talk you in or out of anything, but I'm wondering if he's talking about focused radiation, he's probably not talking about 40 days unless he said so. He's probably talking about SBRT, which is more like.
No. I asked him about that. He wasn't talking about SBRT.
All right.
Yeah, I asked him about that.
Yeah, I don't know why, but for proton beam, they always have many sessions, much more than you would with, certainly much more than SBRT, and it seems to me even more than IMRT.
Yeah. Well, I kind of wonder, why you wouldn't do SBRT. If he can aim accurately, and But again, it was really surprising to me that he said it could be a false positive.
Yep.
So.
Scott Ramsos, you have your hand raised.
I just wanted to say, and again, I'm not here to talk to you either way, one way or the other. I just came off of radiation myself for my neck, and I've lost 20 pounds in a week because I just can't eat. It's sore for me to talk. The same rad-onc talked me out of getting my prostate radiated, just due to the simple fact that I didn't necessarily need it because I was not having any problems urinating. But he then did kind of talk me into getting my neck radiated. So I'm not 100% sold on getting everything radiated like I was during my initial diagnosis. That's all I wanted to say.
Thank you.
Thank you.
Yeah.
Okay, Paul, I think you can go and pick up your family.
Yeah. Okay. Well, thank you for the time. I appreciate it.
You're welcome. Now we
Don't-
had a
Don't,
caller.
Paul, don't forget to schedule that MRI. That's what I would definitely do.
You think I should
No,
definitely have the MRI?
I would. There's no downside to it, and it's going to give you a much better information. Right now, you don't really, you're not sure if there's something there. There isn't something there. I mean, what is the downside of getting the MRI, which is what Dr. Jack said and what Len said, and I just don't see the downside. Why not?
Yeah. Okay. I'm going to think about that hard. Good argument.
Okay, we have
Thank
a
you.
recent, you're welcome. We have a recent caller on the telephone. Can you identify yourself?
Hello, everybody. This is Henry.
Hello, Henry.
How's everybody doing? How's
We're
everybody?
doing well. We'll label you. Welcome,
Okay.
Henry.
Thank you, sir. Appreciate it.
And Jimmy G is with us. Jimmy, are you all right tonight? You need anything?
Oh, I'm fantastic, sir. Thank you for asking.
All right. Okay, let's see who have we got next. Did Paul Harry Spila, you're up.
Hi, everybody. I have more of a question than anything else. As I'm sure with everybody here, or most people at least, part of this treatment journey with ADT therapies has gained weight. I've struggled with it quite a bit since 2016, and I'm going to be talking to my physician about maybe trying one of the weight loss medications. And I was just curious if anyone has had any experience with this. When I first had my drug holiday for a couple of years, I was able to lose quite a bit of the weight I gained. But then when I had a reoccurrence and went back on ADT, the weight came back very quickly, and I just struggled to try and drop it. It's just very frustrating. So I'm gonna be looking for maybe some help in the form of some medications. I was just curious if anyone has had any experience using any of those.
Yeah, go ahead, Joel. I know you've been on those drugs.
Yeah, I was on Mounjaro from September 15 last year to December 15 last year. I wanted to lose 50 pounds. I lost 25 pounds. I got allergic to it. I got a rash. I understand from a nurse practitioner that I talked to a week ago that if I had kept on taking it, I could have gotten into nausea and diarrhea and so on. But I did stop, and since then I've put on another seven. I went down from 255 to 230. Since then, I put on about 7 pounds back on. I'm trying my darndest not to do that, but the Mounjaro certainly cuts off your hunger pains. You feel full all the time. You don't want to eat between meals. It's an amazing drug from that standpoint. But you may not be allergic to it, so you may do very well on it. So I can't advise you whether or not you should go on it. But my blood count got screwed up because of some of the radiation that I had, SBRT radiation I had back in November, December. I'm waiting for my blood levels to get back to normal before I attempt maybe another drug like Ozempic or Wegovy or whatever. So, but it does work for sure.
Okay.
So from
Yeah, I'm
what I've
hoping.
heard, and this is strictly from the news, is that once you stop those drugs, you put the weight back on. And even after about a year or so, you kind of plateau and you can't lose any more weight. So even if you stay on the drug, you're not losing any more weight. If you come off, you put it back on. Dr. Jeff, you know more about this?
Well, I'm not a big fan of these drugs for the reasons you just said. However, I'm in the same boat as Harry. in that I put on about 18 pounds since I started the ADT and the abiraterone and the prednisone. So I had a consult, Harry, with a nutritionist about 3 weeks ago, and we decided that I would try intermittent fasting 16/8. So I eat from 9 in the morning until 5 at night, and then I don't eat until 9 the next morning. 8 hours of eating, 16 hours of fasting. And the goal is to lose in the neighborhood of about a pound a week. So it's not super quick, but prostate cancer treatment is a marathon, and so is intermittent fasting. So in the 3 weeks, I've lost 4 pounds. I am not hungry, not at all. As a matter of fact, it used to be I used to get up at 6 in the morning. I took my abiraterone, waited an hour, and I had to eat. I do not feel the need to eat anymore. So maybe talk to a nutritionist, and I could say so far this intermittent fasting is at 16/8 is working.
How much exercise are you doing along with that?
Yeah, so I walk, and I do between a mile and a mile and a half walking every day that I can. I push myself to do it. I'm tired, but I know how important it is to, not allow osteoporosis and muscle wasting to take place.
Yeah,
Jeff,
yeah,
are you still
I've read
doing?
about that. That's something maybe I'll look into. I'm planning to go on another drug holiday, and so my hope was, in combination with that and the drug, um, that I can lose some weight. I mean, I already ride. I cycle quite a bit, 15, 20 miles at a time, about 4 times a week, and pretty active otherwise. And I just I can't drop the weight. It's crazy. So,
Jimmy
but
Greenfield.
Yeah, I just want to say that, the reports are definitely in that these drugs work. The only issue for us, I think, is that you lose fat, but you also lose muscle on these drugs. And you're losing muscle anyway if you're on ADT unless you intervene. And with all due respect to the doctor, walking is a limited way to keep from losing your muscle mass. I always was a proponent of weight training. But regardless, if you're losing weight on Ozempic or Mounjaro, any of those drugs, you're losing muscle along with the fat. And it's always a challenge, the muscle loss on ADT as it is. So I'll just leave it at that.
all right, thanks. All right, well, thanks everybody.
Okay, anybody else before we move on? Joe Commander, you're up.
Yeah. Uh, whoops. Yeah. Sorry. Having problems there. But I attended a bunch of sessions at Fred Hutch 2 weekends ago, I guess, and 2 Saturdays ago, and they had some slides on that. And besides the losing muscle along with fat point, they said that if you go off the drugs, you tend to gain the fat back, but not the muscle. And the other point that they made was that you have to be really careful about getting a really good nutritious diet. You're not eating as much, and if you're not careful, you also are not getting very good nutrition.
Okay, Joe, was you just wanted to comment on that, or did you have?
No, you, me, or Steve?
Oh, I'm sorry. Who was just speaking? Steve?
That was Steve. Yeah.
Oh, all right. Sorry. Oh, okay. Thank you for that, Steve. And so, Joe, you are up.
Okay. I can't recall what people remember about me, but for the last few years, I've been doing SBRT to whack whatever spot showed up. And they were always on lymph nodes. And my doctors and I think maybe it's run its course. In January, they found 2 spots instead of 1. Didn't really go down that much after the last time they radiated, which was last summer. Um, and one of the new spots is close to one of the old spots, which makes it a little more dangerous to radiate. Does that make sense so far? Um, so we're thinking maybe that, we're done with that. So the next thing is hormone therapy, which is not a big deal to most of you, but is a big deal to me because I've avoided it so far. My situation is that I have 2.1 PSA right now from a couple weeks ago. And my doubling rate is about 10 months. In 10 months it doubles. What else did I need to say? My medical oncologist has encouraged me to think about ADT and the other one, I forget what that's called. Androgen.
Androgen receptor blocker?
Yeah, that's it. And here's what she says. That's I don't pay her to say these things, but sometimes I like what she says. She thinks that I don't need to rush into it because my rate is kind of low. I've floated the idea of not doing anything until I really felt bad, and everybody said, no, that's crazy. You don't want to do that. But she had sort of a modified version of that where she said, I don't if you're really scared about the spread of the cancer, we can start right away. But if you're not as concerned, I think we can wait, maybe 6 weeks or 6 months or something like that, see where we are, and then start then. So I jump at stuff like that, but in a way, I'm asking you guys what you think of that. I'll just stop there for now. I have a couple of other questions related to that, but I'll stop there.
Joe, what was your Gleason?
4.3. I get mixed up about that, but I'm pretty sure it was 4.3.
Yeah. Well,
And I've, it's kind of gone up and then we shoot it down and then it goes up again and shoot it down. But since my prostatectomy, it hasn't been, this is as high as it's ever gotten. It never gets way up. Hasn't so far.
yeah, I guess it just comes down to how comfortable you are waiting those 6 weeks or 6 months
6 months.
and potentially watching your PSA rise without doing anything.
Mm-hmm.
If you're comfortable with that, you might want to take her advice. If you're not, if you're nervous, as she said, maybe you should start.
Yeah. I tend to be nervous.
Actually, I don't know, Rick, you want to chime in about the triplet therapy? Is that appropriate here for Joe?
You were reading my mind, but you go ahead and chime in. Go on. He doesn't. I don't think that Joe wants to hear it.
No, I probably don't, but I can. But go ahead, tell me.
Go ahead, Len.
Oh, I was leaving it up to you, Rick, because all I did is read the abstract. I didn't get to read the paper. I've been meaning to ask you for a copy of the paper.
I don't have the
Oh, you
paper,
don't?
Len. I mentioned I don't have the paper. We have to get it from somebody.
This is also my
We
question.
only have the abstract.
Yeah.
And this is my question that I have too about that paper.
Oh, hey, Jack, did you read the paper?
No, I didn't. I didn't. They have to pay for the paper, but I read the abstract, and I really want to question a little more about it because I want to know what kind of overall survival benefit you get in terms of time. I mean, if you get an extra 3 to 6 months, is it worth it all? I'd like to know more specifics about if you go triplet for hormone sensitive, as I am, and I'm getting doublet. He said to me, no, triplet's not good for you. Your white count's too low. He said, you only got a couple of spots, you're oligometastatic. This paper comes out saying it doesn't make a difference whether you're oligometastatic or multimetastatic. Anybody is going to do better overall survival. And Jesus, I'd like to know more specifics about that. I've never heard that before.
So before we go off on each person's individual conversation, and I already see two hands, so there's going to be some conversation on this one. Then let's explain to Joe what we're talking about. Joe,
I read the abstract also.
Oh, you did read the abstract.
Yeah.
So you know what we're talking about.
Yes,
and
I do.
It's well, I mean, I would say it's watershed. It's revolutionary. I mean, no matter what the situation, if your disease comes back, get chemo. I mean, I think that it needs fine tuning, just like Jack says. I think in principle, we're getting the message, but we don't know. Dr. John just arrived in time. He can probably hear us. Dr. John, the one man who can probably get access to the abstract from Doctors Hussein Fasazi and Shore, that people with metastatic hormone-sensitive prostate cancer need triplet therapy. Have you by any chance read that abstract, Dr. John?
I think I read more than the abstract. Let me just take a look here.
Because it's just come up in the context of Joe Commando, what to do next.
Oh, hi, Joe.
Hi.
And we have at least two people who have questions on it, if not more. And of course, none of us have been able to read the paper, but Dr. Jack has a number of questions. So we're wondering if
I've got the paper. I've got the paper downloaded. Is there a way to upload it?
No, but
same here. I have it too.
Oh, you have it. Well, if someone could send it to me, I'll make sure it gets around to all the moderators, because we haven't. We were blocked, unfortunately. It was behind a paywall for us.
I can send it to you, Rick, and then you can distribute it to whoever
Yeah. By the
wants
way,
it.
on the paywall thing, I mean, I'm not a medical researcher, but I think somehow I just went to the JAMA website and signed up, and I get their emails, and then there's a link in the email that gets past the paywall. So I just signed up at their website, and
Yeah,
I
I
didn't
am
have to
signed
have
up
an affiliation or anything.
I'm signed up as well, but I can't get past the paywall. So maybe you need a name like Schuler. I mean, doesn't that mean scholar in German?
It does.
Or teacher.
So there you go.
So, Dr. John, did you want to comment now, or?
What kind of questions are coming up? Whether it's really true or not, whether you really do have to have triplet therapy, even if you have low risk disease.
Yeah,
Is that the kind of thing you guys
for
are
instance,
discussing?
Joe Commanda is a 4+3. We were wondering, would it be appropriate for someone like him to have triplet therapy? He's never had hormonal therapy before.
Well, then he's not. So he's hormone sensitive, metastatic or no? Metastatic hormone sensitive?
Where were your metastases, Joe? Were they only local in the pelvic region, or?
Yeah, pelvic region, lymph nodes.
Yeah, I don't even think he would be considered metastatic.
Well,
Oh, I think
they
so.
consider me oligometastatic.
Yeah, he's metastatic then, but he NX is still metastatic. It's not local, but technically he's
He's stage
uh
4A. Yep.
yeah, he's metastatic hormone sensitive prostate cancer. I mean the issue that Dr. Jack raised is, well, should you know, what are the outcomes, and how much longer are you going to, what's the overall survival on this? And I think for that, you've got to go back to each of the individual papers and each of the individual trials and read it and come to your own conclusion. I mean, I don't really know how they arrived at this conclusion. I mean, I was sort of interested to read the discussion in the paper, which I will do. But those are the sorts of questions coming up, Dr. John. I mean, it seems like Hussein and Fizazi and Shore have arrived at this recommendation based on comparing the various trials. I don't know.
Yeah.
Maybe we'll get Harry Spieler to ask Dr. Hussein how she came up with this conclusion. Send her, maybe Harry can send her a note and find out, because we're all very curious.
I have an appointment with her next week.
There you go. Perfect. Do you know about this paper, Harry?
No, I'm not familiar, but if you want to send me an email, I'll be happy to ask her anything.
Yeah. Well, just watch out, because if you're metastatic hormone sensitive, she may be recommending chemotherapy next week.
What's Joe's PSA these days?
2.1 last week,
2.1, and it
2 weeks ago.
was, and has it been rising?
Yeah, it's been rising slowly from last summer.
Any
I think he said he had a
mutations?
10-month doubling time.
10 months? That's kind of right at the cutoff, isn't it? But they are starting to think that maybe that doesn't even matter that much, I suppose. Well, I don't know if anybody would do it based on simply one paper, but I think Joe might have been the kind of guy that was in this, one of the, data points in this study. Looks like I lost it. I had it on my, I had a whole bunch of things open today, and I was really working away at these this weekend. So I must have obliterated it. It's probably underneath one of my other papers. I'll find it and I'll send it to Rick and anybody else that wants it, and you can see what you think.
Dr.
It's
Jeff
not.
posted a
It's
link.
not a tiny little trivial paper, though. I mean, it's not something we can just say, "Oh, phew, it's just a little, a little thing with not many." I think it was quite significant.
And Dr. Jeff has put another study in the chat window, which I don't know if that was referenced in the paper or not, but that's a completely different study from when was that? When was this? I can't see a date on it. But anyway, April of 2024. So it's also very recent. So there's one from April 2024, and now there's this one with Hussein, Fizazi, and Shore. So I'll take a look at that. John, if you send it, would it be possible to send the paper rather than copying it onto the email? That would be better. Or if somebody could send me the PDF, that would be best.
Somebody said in the chat, somebody said he sent it to you.
Yeah.
Oh,
Yeah,
thanks.
Matt.
Thanks a
Matt
lot, Matt.
said he sent
Great.
you the PDF.
Great. And I'll make sure it gets round to everybody that I know is anxious to see it right now. I'll get it to Scott. I'll get it to Matt. I'll get it to Adam, and I'll get it to Joe.
And Could you get
And
it to me
so,
too, Rick?
and I'll send it to you. Yeah, I'll try and remember everybody. Better make a note to myself, otherwise.
All right, so
Sign
let's
me up,
let's
Rick. Jim
postpone.
Marshall.
Okay.
Let's postpone any comments on this triplet therapy idea until we've all had a chance to read the paper.
But that said, Len, I think that we still come back to Joe. We don't want to throw him in at the deep end. And the question for Joe is, what's his best strategy? When should he start hormone therapy, and what should he start? I mean, prior to reading this paper, or these two papers, I think we would have said, yeah, you've got to jump in with a doublet, LHRH plus a second line anti-androgen. I mean, my own personal view is, if it were me, I'd do it sooner rather than later, because the longer you leave it there when you know that something's growing, the harder it is to control. So from my standpoint, that's what I would want to do. But
Joe, do you still have your prostate?
No, that
Okay.
started out with prostatectomy back in 2013.
Okay, so that PSA of 2 is presumably all from MHSPC.
Right.
So,
what did you respond to in the past? Like, did you get put on Lupron and your PSA went
No,
down to
I've never had
nothing?
any hormone or chemotherapy.
Oh boy.
I've had
Okay.
radiation. Since the prostatectomy, I've had radiation, prostate bed radiation, and then more recently, SBRT.
They were willing to do prostate radiation without putting you on hormone therapy? First?
Yeah, they did. That's what they did.
Was that your choice or theirs?
It's a little hard to say. I know that when they did the prostatectomy, I wouldn't have even contemplated radiation. It just sounded so horrible. And then 3 years later, they said, well, guess what? It's going up again. And all of a sudden, radiation sounded pretty good, So I don't think that I was rejecting hormone therapy at that point. It wasn't proposed to me.
Huh. Where were you being treated, Joe?
At that time, I was being treated at Abington. Well, now it would be a part of Jefferson Hospital in the Philadelphia area. And since then, I've moved over to Fox Chase.
So, Dr. Jack, it's not unusual in community-based radiation oncology practices that they do not add hormone therapy. Especially, well, it's not unusual, but I think that in the last set of advanced astro guidelines, AUA astro guidelines, it was recommended, but not required.
Yeah, this was probably 2016 or so, give or take a year.
Wow, that's a long time ago.
It is.
Yeah.
That's a really long time ago.
Yeah.
So you've just been hovering these relatively low PSAs all this time without any treatment?
Right.
Wow. Well, it sure doesn't sound like
I didn't
the
I didn't
kind
do
of
it myself.
it sounds like the kind doesn't sound like the kind of aggressive kind of thing that somebody would jump on triple therapy for. But
No,
then
no.
maybe it doesn't matter anymore whether you're high volume, fast doubling time, and all that stuff. I guess that's what we have to figure out.
Yeah.
Yeah, I mean, exactly right, Dr. John. I mean, the paper no longer seems to make a distinction between high volume Mets and low volume Mets. And of course, this is one of the issues that's bothering Dr. Jack and others. So the question is, what does make a difference? Does anything make a difference? Or is this going to be like breast cancer where they'll basically give you chemo and radiation and surgery, whatever your diagnosis?
What about a PET scan for restaging?
Yeah. When did you get your last scan?
Are you asking
Joe?
me?
Yeah.
January.
What did it show? Just in the bladder?
That showed those two
Just in the
spots.
pelvic? Hmm.
Yes.
Okay.
Let me throw this out and tell me what's wrong with the way I'm thinking. We know that chemotherapy attacks rapidly dividing cells because it messes around with the microtubules skeletons. So if you have a cancer cell that's not growing very fast, I don't see how chemotherapy is going to, let's put it this way, I don't see how the risk-benefit ratio is favorable for chemotherapy in a very slowly growing cancer.
Well, makes sense if your premise is correct.
Right.
Well,
Yeah.
who was in the original Harrison's or whatever it was where triplet therapy first came up? Did they all have were they all high risk people with rapidly growing tumors and doubling times of 9 months or less? I mean, I don't remember.
I
Who
think, but I'm not sure. I think that I don't know if they were rapidly doubling, but I think that they were all high volume. And I think that's where that high volume, there were 3 trials. There was Peace, there was Harrison's, and what, do you remember what the other one was off the top of your head? Len, but there was one for there was one for Abby, there was one for enzalutamide, and there was one for darolutamide.
Right.
And I can't remember which was which. But I think
Well,
the common
darolutamide was Arisens.
Right.
Peace one, Harrison,
And the I think Enzamet.
Enzamet.
Yeah.
Yes, Enzamet was enzalutamide, and Peace was abiraterone, I think.
Yeah.
Right.
Yeah.
Peace one.
And the common thing, as I recall, and I could be wrong because it's a while. These are not that recent. Those recent trials was that they all said if you got high volume Mets, chemotherapy is appropriate. And that sort of followed up on what was the trial years ago that had the one in England that has all the different arms that just keeps on going and going and going. I forget the name of it.
Yeah.
But anyway, that's what we always thought. And then they come out this week and they say, doesn't make a whole heck of a lot of difference if you're metastatic hormone sensitive, get chemo. At least that's what we think it says. Has anybody, I don't, Stampede. Thank you, Steve Schuler. Yeah, Stampede, that they all developed on Stampede. See, the wisdom of the community, it's great. has anybody actually read the paper in full? Dr. John may have done. Matt, did you actually read the paper yet, or is it still sitting in your to-do file?
I read it enough to realize I don't know what's going on. And you suggested talking to my doctor about it, and he's just back
Yeah.
to work on Monday or Tuesday, and he's already emailed me that he'd love to chat. So I'm gonna talk to him about this stuff.
Okay. And Adam has had those attacks already anyway, but I'm sure he's interested in what it says. Scott will send the paper to, but I don't think he's seen it. Who else said they downloaded it? Somebody else. Matt said it, and somebody else said they had it. Oh, Steve Schuler. Steve Schuler, did you? You're on the money, man.
Yeah, I
You know
sent it.
what to read.
I also sent it to you. I sent it
Okay,
to you.
now, but did you read it yet? Because we can rely on you.
Yeah,
Come on. You did.
yeah, I
So,
read it. And the evidence was pretty good. Some of the, I mean, some of the, it was a meta-analysis of a lot of different things, and some of them showed an advantage for of the protocol for de novo versus recurrent, and others the other way around. And some showed it for, I think the, yeah, I mean, it was, they all showed advantage, but the individual gradations of, what was best, it seemed to be kind of different in the different studies. So that part is uncertain, I think.
and what did you take out of it? I mean, you're kind of in that bucket, aren't you? I mean, what would
Yeah,
happen
yeah. I
if
mean,
your new doc
so
turned around and said, "Chemo for you, Mr. Schuler"?
yeah, I would probably go for it, I guess. My take on things is, it's not based on any medical background. It's just my reading and kind of my thinking about how this stuff grows, right? I mean, if it were a pure exponential curve, it wouldn't really matter when you did these protocols. But there's two things. One, it's not pure exponential. It mutates, right? So my guess is it's probably best to cut it off at the knees before it gets too many mutant clones. So that's my guess. That why it's better to do these protocols earlier. And it seems to me, my observation is that they keep pushing the protocols earlier, and it's not because the docs thought it wasn't a good idea to push them earlier. It's because that's how the studies got done, right? You started with the people who were worst off first,
Yeah,
and then you
yeah.
pushed the protocol earlier and earlier. And so that's what we're seeing is an evolution. It's not because people thought that was a bad idea 10 years ago. It's just that they hadn't done the study yet.
So, Adam, you had triplet therapy. How did you respond to it? How long ago?
Well, my last round of chemo was in January. So I'm still feeling some of the effects, I think. But, I mean, the response wasn't, all things considered, it wasn't bad. I got the metallic taste in the mouth, extreme fatigue. It's more of a mental, mess with me mentally more than anything else. I'm still trying to grow back hair. I only just recently was able to grow the beard back out, probably about 3 weeks ago. Ironically, they put a port in for the administration of mine. Although, as young as I am, if I had to do it again, I wouldn't have gotten the port. I don't really think. I think I was probably healthy enough to where I could have done without it. But I got the port. When they took the port out, they had some issues with that. But ironically, this side where the port was on the left side of my face and body, the hair is taking a lot longer to grow back. Um, but other than that, I mean, I wouldn't do it again. I don't ever want to do chemo again, but it was whatever. An hour in the chair, you're in and out. Six. I would have done it. I would have stopped after 4 because there's some other. I think maybe this paper they talked about, or maybe it was Stampede, where they talked about because they used to give docetaxel infinitum, from what I had read, and so they did this study to say, okay, well, instead of doing that, can we cut back on it? And that's where they came up with, 6 being the best number. But if I had to do it again, I probably would have stopped at 4. And the reason being because you do a baseline scan and then you do a scan after 4, or at least my med-onc did, and they showed just stable, no change. But I mean, all the docs say that I have responded very well as far as PSA being down and SUV, the latest at PSMA PET being way down.
Adam, did you have any neuropathy?
Oh yeah, but the neuropathy only came after I finished the chemo. Oddly enough.
See, that's my biggest concern with chemo is it seems to me that everyone I know who's ever had chemo has gotten neuropathy, and it's fairly intractable as far as mitigation is concerned. I don't know that anybody has ever said, yeah, I had neuropathy, but I took such and such a drug and I was fine. And what impressed my memory more than anyone else was Dominic Moresi, who Rick knows very well. He traveled all over trying everything to alleviate his neuropathy, and he was never successful. Neuropathy from chemo.
I'm sorry. I did not have neuropathy. I had the issues with the nails, but from nerve endings and things like that, the only thing that hasn't come back right now is just I tend to be retaining a lot of fluids, and I think that's one of the side effects of the chemo. But I apologize. No, I did not get neuropathy.
Oh, okay.
Well,
right.
we're glad to hear you didn't, because you don't want it. The problem is that sometimes, not always, but sometimes that damn neuropathy will follow on a little bit later, as it did with me. And I didn't get chemo. My neuropathy was from the hormone therapy, and I live with it. I continue. It wakes me up at night. I continue. It's a bit miserable, but it's not that bad. But Glenn's right. It is a pretty prevalent side effect. Jimmy, do you have neuropathy from your docetaxel? Jimmy, well, he's got his microphone off and we can't see him, so he must have stepped away.
Yeah.
But I was just wondering, because I know that Jimmy was on a trial, was on a docetaxel trial at the time that his doc convinced him to participate in, and he did, I think, 4 sessions. So I was wondering.
Larry Fish, what are you motioning there? Speak up.
7 years neuropathy since chemo.
7 years of neuropathy from chemo?
Yeah, still 7 years ago.
Yeah,
Still have.
Yeah, that's the typical story that I hear.
Yep.
Jeff Markey, you have your hand raised.
Yeah, I on the other side of this, I mean, I'm a 4+3. I'm 14 years in. I started off with surgery. 3.5 years later, I had radiation. 2.5 years later, I was on Casodex for a year. It kept it down. Then I went on Lupron. That kept it down for another 3 years. Then I went on Abby, that kept it down for another 2.5 years. And I don't think my overall survival would have been any better if I had done a triplet therapy in the beginning. I still have after 6 months of being undetectable on darolutamide, once that starts working, I can go on a PARP inhibitor. Once that starts working, then I can go to chemo. And I mean, how many years is that going to be in? I think there's another way of looking at this, that sequential therapy works for some people too, and it's triplet therapy. Is a real big push for somebody who's castrate sensitive and hasn't been around long with the problem.
Yeah. Well, as Rick commented, you can't say you don't think you do any better on chemo because you just don't know. But we're going to move on.
Adam has his hand up, and I also want to check in with Eric, because Eric had his hand up right at the beginning of the conversation and took it down. Eric first. Eric, what are you thinking?
Oh no, I wasn't about the trial. I know that he was suggested that maybe take about 6 months off before I get in treatment. And I was just going to ask, were they going to give him any scans prior, within the 6 months as a marker to continue to, I guess, to actively watch it.
Right. That's one for you, Joe Commander. What would they do
Yeah, I
during the
think
six
that was their
months?
intention, to watch it and to do we would do another scan and see where we were at.
How about more radiation if there's nothing outside the pelvis? Is that an option?
Well, that's what we have been doing. We've been doing SBRT radiation. I've done it, I don't know, I lose track, 2 or 3 times. I think 2 times.
Yeah.
And the reason to not do it this time, from their point of view, and I think I agree with them, is that one of the new spots is real close to one of the old spots, and that would make the radiation more risky.
Oh.
That's one thing. And the other thing is, the last time we did it, the first time we did it, it really knocked back the PSA. Second time we did it, it just budged it a little bit. Forget the third reason. There was another one too.
And Adam, you had your hand up.
Yeah, the only other thing I was going to say was I think because again, when I was going through it, I had a lot of these questions, and the other thing that my med-onc said was the paper demonstrated was the docetaxel, especially if you're doing it close in the beginning, should make your system should make the first line and second line, first generation, second generation, more effective longer, is what they told me.
By doing it earlier rather than later, is that what you're saying?
Well, yeah, whenever you do it. I mean, typically, again, earlier in my case, because it was the first thing they did, but I was de novo, metastatic.
Right.
But who knows?
There is a thought that there's some synergy from these treatments. I mean, just one example, not strictly related, but as Joel and others will tell you, Dr. E loves to give radiation or suggests radiation if you do any type of immunotherapy, because she thinks that there is a synergy between the two and they work better together. And so I don't think we know enough about the synergy of treatments. At least I certainly don't, but maybe Len and Dr. John do.
Well, we definitely know synergy between radiation and hormonal therapy. That's well established.
Mm-hmm. 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 Yes, you're right.
Adam, are you in? Are you in Florida, Adam? You've got that archetypal Florida
Yeah, I'm in Panama.
lanai structure behind you. Huh?
Yeah, yeah, I'm in Panama City.
Oh, you're in Panama City. Okay. All right, guys. Let's see. So, Dr. Jack, do you still want to take some time?
No, I really just wanted to get into the weeds on that whole thing that we've been talking
Yeah.
about all night. So I'll just wait until we have more information. Maybe
Yeah.
Rick, when he gets that paper, I'd like to read it closely. You have to belong to some kind of institution to get that paper, and currently I don't belong to any institutions. So
Right.
I'm not able to get it unless I want to find some.
You're
trivia.
on my list, Dr. Jack. You're on
Thank
my
you.
list to get it.
Thank you. I appreciate it, Rick.
Thank Matt. Don't thank me, and thank Steve Schuler. They're the people to thank.
Thank you, Steve Schuler. Thank you, Matt.
Okay. Now, Eric, I had you down. Would you like time now?
Yeah, sure. So just a little update. So I was having some trouble with my insurance getting medicine, so it looked like that's going to be resolved. So it looked like I'll be starting enzalutamide and Lupron pretty soon. And I did talk to my doctor, Dr. Marshall. She is going to give me the the blocker shot before I start the Lupron. And
Right.
I'm feeling pretty good, but I have a little anxiety about the side effects from the drugs. So I don't know what to expect from it. I was on Orgovix one time, and it wasn't bad. I had hot flashes, from time to time, but that was it. But I'm in a new ball game with the new drug, so I'm not sure what to really expect from how it actually is going to affect me. But that was it. So I just wanted to
Okay.
give an update. So
And the new drugs are Lupron and what else?
enzalutamide.
Enzalutamide. So the Lupron will give you side effects similar to the Orgovix.
Okay.
Enzalutamide will probably make you feel more fatigued. That's how most guys respond to it.
Okay.
And including some brain fog. If we have any guys, it doesn't affect everyone that way, but I would say most. So if we have any guys who are now on enzalutamide or who have been on it, you want to take some time on the floor? Must have somebody. Nobody? Enzalutamide? Really?
I'm back on enzalutamide. I tried darolutamide and it failed for me, so I had to go back on enzalutamide. And
Right. So
the reason I went to darolutamide is because of the brain fog and the fatigue. But I did even worse on darolutamide, so I can live with the enzalutamide, and that's where I'm back on that now.
okay. And Eric, we should say that Mark is, as far as darolutamide is concerned, he's more the exception that proves the rule. That darolutamide is far gentler in the areas of fatigue and brain fog than enzalutamide.
Yeah,
But not,
I wanted to get darolutamide, but I wasn't. The only way I probably could have got it was to join the blind trial with that. But so
right.
yeah.
Or if you're willing to take docetaxel with it, then they'll give it to you.
Docetaxel.
That's the
What is that?
chemotherapy.
Oh, okay.
Yeah, because darolutamide is approved for use with docetaxel and hormonal therapy.
Oh yeah,
ADT.
my doctor, she doesn't want to. She won't do that. She says she doesn't want me to take it. I'm nowhere near chemo or something like that. She says so. No,
Okay.
she won't do that.
Maybe she needs to look at this new paper as well, Eric. I should add you. I'll add you to the distribution, and you
Yeah,
can see
yeah,
what we can see what she thinks of it too.
yeah.
Um, I guess. I mean, you're a younger guy, and
Yes.
I would love to ask Adam again. We keep picking on Adam today, or Scott. What about Scott Romsas? Aren't you, Scott? Aren't you? You're a younger gent. Yes, you may be the man. Are you with us, Scott? Are you there? Because I think Scott's probably the best for you. Scott's on recently started hormone therapy, and yes,
I'm
he's
here.
there. You're there. Okay. You recently started hormone therapy and a second line anti-androgen, correct?
Well, I'm on the shot in the stomach and Erlita.
And Alida, perfect. So
Mhm.
Alida, Eric, is very, very, very similar to enzalutamide.
Mhm.
So the question that Eric has is, what should he expect when he starts the LHRH drug and the enzalutamide? So how did you respond when you started? And he's also a younger guy like you.
So I have slept a whole lot more than I ever have in my entire life. Um, I'll do the dishes or I'll go and mow the lawn and then I've got to take a nap for an hour. Um, I'm going to go back to teaching in the fall and I'm a little bit nervous about being with a group of students for the full day. Brain fog, my testicles have shrunk, my penis has shrunk. So those are some of the main ones that I'm dealing with. They're not fun.
Mm.
But my PSA level has also dropped from 66 down to 0.2 in just a month or two. So
Okay.
it's really, really working for me, but there's definitely some downsides to it.
Mm. Yeah. Okay.
Thomas Matika, do you have any experience with enzalutamide?
No, I do not, but I just want to back up for a second and say that I'm on Firmagon and darolutamide, and I'm not taking docetaxel. My doc, Dr. Sokolova at OHSU, from the beginning of the darolutamide, seemed to have no problem thinking that she could prescribe it for me without having to use the chemo. So I just wanted to bring that out.
Yeah, by the way, Eric, if you can get darolutamide direct from Bayer under their patient assistance program for free if you qualify, if your income is uh, lower than 81,000 a year.
No.
So you can pursue that.
Yeah. That would disqualify me.
Okay.
Yeah.
Okay.
That's okay. We could just ask you for a loan in that case, Eric. Look, first of all, please, guys, Eric and Scott and all you younger guys, exchange emails because you all need to support each other. It's huge. It makes a big, big difference. I know. And I'm thinking right now, Eric and Scott, because you're going to be going through similar things, even though, Eric, you're recurrent and Scott was de novo metastatic. Secondly, Eric, what I want to say to you is that my own peer experience was a little different because I was only on LHRH, because back in the day, these second line anti-androgens were just not prescribed for people at my stage. I was stage 3, and they weren't prescribed, although now they might prescribe them. So I can't tell you about the combination, but it's not easy. I think the best advice I personally can give anybody is to exercise. I mean, and I don't want to sound like a broken record,
Mhm.
and I don't want to sound like Jimmy Greenfield, but it is so important because it combats so many of the side effects that you're going to feel. And yes, you will feel fatigued. You can't help it. It comes with the territory.
Mhm.
And a lot of us have found the same thing. You basically can do one activity a day, and you have to choose what the activity is. Now,
Mhm.
how well can you manage it at the same time as working? Not really sure. I mean, Scott has found that was hard. I think Adam was going through even more with the docetaxel as well.
Mhm.
Matt is still down the pike. He's just starting on the hormone therapy part of it, so he's not sure. But guys, what have you found when you've started hormone therapy, and what advice can you give to Eric? And I think everybody on this call has been through that experience, except maybe
Mhm.
Joe Commander.
Yeah.
Adam, go ahead.
I think you said it, Rick, as far as the exercise. I think exercise, part of, if I had it all over to do again, I'm a pretty active person, but I was told at the time, because they didn't have, just, we weren't really sure, and I really didn't understand as far as the spread from a bone metastasis. But they were like, hey, some of my other medical friends who weren't oncologists, they were just, either emergency room docs or urologists, and they were just like, hey, hold off on the weight bearing exercises. And so I stopped my weight bearing exercises because I did a lot of them. And yes, for some, if you have a lot of bone mets in certain places that are certain advanced, then maybe I've got a friend who's 70 something who he shouldn't be doing a lot of it for risk of pelvic fracture or something. But for me, and for you probably, don't stop weight bearing exercises. Don't stop weight training. When I got my
Great
port in,
advice.
they told me to stop doing anything for the overhead movements because they didn't want the port to flip over, which I can kind of understand. But so again, I stopped and just stayed doing cardio, which was running, and so I broke a sweat each time. But yeah, just to get off here, my advice would be exercise. Continue to exercise. I mean, I'm training for a triathlon right now. Hope to do a half Ironman here in a year. So that's going to be really difficult, but that's what I'm trying to do. So I think that really helps mitigate it for me.
Yeah. Yeah. So one of my, like I said, my biggest fear too was that, so I just got a promotion, so I don't know if I need to talk to, my directors or powers that be to say, hey, I'm gonna be going through this treatment. There might be, a little sluggishness from time to time. I'm just contemplating on how I should handle that. But overall, I do
Anybody?
stay
would wait and
I do
see.
stay active. Okay.
I would wait and see, Eric, how you actually feel.
Mm,
Maybe you'll be one of the lucky ones, and you won't be affected to the point where it affects your work.
right.
But if that is the case, then yeah, you probably should talk to your boss.
Mm.
Matt, go ahead. I can see, I know you've just dealt with this situation a little bit.
Yeah, I mean, it depends on your workplace, like everybody. I'm just on the, I was going through the melanoma treatment, and I started by not telling anybody anything, and then I waited too long and it kind of hit me too hard, and I think it probably put me in a bigger hole in January when I had a reaction to the infusion therapy, but nothing irreversible. And I've been pretty open with the key people. I didn't realize I was going to be so open, but I was. You mentioned the promotion.
Mhm.
I got to admit, I did wait until uh, I just waited some end of year budget changes and things in the organization that were beneficial to me. I did wait till that process was over, because there was no reason to overshare through that point. And um, one of the emails that Rick or AnCan sent out, auto sends, did have a good link that I just coincidentally looked at Saturday. It was about careers in cancer, and they have a conference coming up, and they had a ton of great links in there about,
Yep.
talking with your employer, talking with your coworkers, talking with the people that report to you, and all the legal rights around that. So I only put my toe in the water in it, but I found it really helpful.
Okay, I got to take a look at that. I haven't seen it. I haven't noticed
Yeah,
that.
and I'll try and find it right now and put it in the chat window. But there is a Cancer and Careers conference coming up, and those folks are really good. You can call them up. They can help you with all of this. In fact, they specialize in doing that. Scott, what did you want to say?
I've got a couple of things. I just interviewed for a brand new job. I've been a teacher for pushing 30 years. I just interviewed for a brand new job today at the age of 54 as a county extension agent manager. And I was very upfront with them with my recent diagnosis. I said, I honestly don't know if I'll be here every single day. I may have to go to Salt Lake City for treatments, different things like that. But I also kind of wanted to talk about what Adam was talking about. I try to do a hike every day with my dogs, and it's 2.5 miles, and that is typically one of the best things I can do. It helps me mentally, number one, but physically, I just feel a little bit more alert if I'm doing a little bit of just a hike myself. So that was kind of what I wanted to say, Eric.
Okay. I mean, it's ironic because now keep it short. It's like I look at things. Everything has a pro and con about it. Everything has pros and cons about it. And one of the positive things that came out of this, this cancer journey, is that I'm in the best shape of my life since I was like 25 years old. So, so I mean, I do work out. I do those things. I drop down. I'm in the ideal weight about 185 pounds. So I stay active, and I just so I'm looking forward to that. Like I said, everything has positive pros and cons about it. And one of the positive things is that, hey, without this, I probably wouldn't be in the shape that I'm in right now. So take it for what it's worth. But I'm
Good
here.
for you.
Mhm.
Yeah, good for you, Eric. Glad to hear that.
So I
Let's
put
keep this in
the
mind too, guys, which is that for fatigue is a universal symptom for all cancers, just the nature of the illness. You will feel fatigued. Go ahead, Rick. You were going to say something.
Oh no, I think I appreciate what you just said, Len. I just wanted to tell Eric and anybody else who might be interested that Matt was kind enough to put the link to the conference in the
Yep, I
chat,
got it.
and I've posted underneath the verbiage that went with it, which is in our reminder. So, and you'll find it in this week's reminder. If you haven't opened it yet, you'll find it there too. But I can't say enough good things about Cancer and Careers, and they have specialists, navigators on staff, so you can call up and discuss your own personal situation, and they don't charge for that. So they'll talk you through it, and those people have a lot more experience than most of us old fogies do. And the other thing I do want to mention, just give a plug, and I know you younger guys, most of you have been there, but the under 60s group, which won't be meeting until the second Thursday of June. This is a lot of what we talk about in there. This is so. If we get all of you, we get Scott and Matt and Adam and Eric in that next meeting on the second Thursday of June, which will be the 12th. No, the 13th. We'll have a really good conversation. So
Yeah.
I look forward to it.
Yeah.
And Eric, talk to the other guys too. One of the things about why I think AnCan is more successful than most other support groups is that we're totally peer driven. And there's no counselor in here. There's no social worker telling us what we can say and we can't say. Yeah, we got a couple of professionals, but Dr. John's appeared, Dr. Jack's appeared, Dr. Jeff's appeared. We only have professionals whose names start with J, by the way. And you cannot. Peer advice is priceless. It's priceless. I mean, what Matt just went through in dealing with his bosses, at the zoo, at the Sacramento Zoo, you can't buy that advice from anybody. You can't. It's immense. So that's why we want you guys to talk to each other. I mean, somebody like Scott going looking for a new job whilst in treatment and 54. These guys are valuable, so make sure you have each other's. And if you don't have anybody's email address, send a note to me, and I'll make sure to connect you. As some of the people will tell you on here, I'm good at connecting people to other people. That's probably my strongest suit.
Okay.
Who else you got there? Who else you got there, Len?
I've got Richard in Virginia.
This is interesting. I better back up, I guess.
You looking for a job too, Richard? You looking for a new
No,
job as well?
no, that's a long time ago.
Okay.
Basically, when I started, well, I have the foamy gland, foamy cell cancer without a Gleason or anything else. And PSA is not very indicative of anything. Basically, metastasis is heavily into the lungs in the hundreds of nodules, and prostate itself and the surrounding areas there. But the first thing that Dr. Allen down here at Share and Markowski up at Johns Hopkins did is, of course, the went to the Lupron and started the ADT, went to prednisone daily, and started with the chemotherapy with the doxytaxel, and that lasted. That chemo lasted for 18 weeks. I did well, except my white blood cells blood count went down. Then I went on to Abbey when I came off of that. Kept everything else going. They've kept everything going. And then the index nodule size and lymph node sizes actually started to go back up again. And then last August, I've now been on the cabitazole chemo. And now the good news is the last 6 months, one of the index nodules in the lungs actually was reduced in size, and everything else has remained static for 6 months, except for the one that was reduced. So every 3 months, the CT scans, bone scan, The only thing the bone scan has found so far is where I cracked a rib trying to fix a fence. Um, so I know listening to people, the it hasn't been all that bad, all the treatments, um, all except for the neuropathy. So I guess
Richard, you said you were taking docetaxel for 18 weeks, which sounds like just
which is
three,
6 rounds, 3.
3 weeks. Oh,
Yeah,
okay, right, right.
yeah.
So
The
the
neuropathy and
cabazitaxel,
weight gain have been the big issues.
the cabazitaxel seems to have worked better than the docetaxel. Is that right?
Yeah,
Very
although
interesting.
you know, they talked to me about, hey, as long as it's working, we'll stay with it. But uh, I could go back to the doxy Taxol again. Uh, now that I've had that recovery, and the only chemistry issue has been a slight decrease in B12, and treating the hypertension and diabetes at the same time. But those, so, but I'm happy, and we'll keep going every 3 months, and be happy at it. And it isn't as bad as everybody seems to think it is.
So hold on a minute, Richard. 3 months or 3 weeks? How often are you getting the cabazitaxel?
Oh, the treatments are every 3 weeks.
Right.
All the scans, the bone and the CT, are routinely every 3 months. The what is it? The bone density every 2 years. And by the way,
Right.
that came out the same as 2 years. I just had that, and that basically the same as 2 years ago. And for somebody who's like 79 now, well, this month, um, that isn't bad. So I would have to say, yeah, it's a lot of crap to put up with. I don't know how else to put it, but it isn't as bad as I hear a lot of people say it is.
Well, that it isn't as bad for you, Richard. Everybody reacts differently.
Yeah.
We know guys who couldn't take more than 2 rounds of chemo. I think Herb only had 2 rounds, Rick, isn't that right?
Yeah,
But good
but
for
one
you.
thing
You're able to,
to
sorry?
tolerate. You're able to
Yeah.
tolerate. But one thing we should make clear to people listening is that the cabazitaxel is supposed to be an easier chemo to tolerate than the docetaxel. But it's also supposed to follow the docetaxel exactly the way that Richard is getting it. And, Richard has done, I don't know how many, there's 16, 17 sessions of cabazitaxel at this time, but he's tolerating it well. I mean, we've known people do 35 to 40 sessions of chemotherapy, some all docetaxel. I mean, I knew somebody before they even introduced cabazitaxel who did that, and he tolerated it well. So Len's point is really important. Some people can
Oh, yeah.
tolerate it, some people cannot.
And Mark Mikowski, basically, he's had patients with like 26 successive bouts. So,
Well, how many cabazitaxel have you had now, Mr. Craymond?
The 12.
12. 12 plus we'll give you credit for another 6 docetaxel, right?
Right. Also,
So we're
also the
waiting.
and the ATD.
Yes, but we're
Or
just
ATT.
we're only giving out medals for chemo.
Okay.
Okay.
Oh, by the way,
So yeah.
Dr. Allen does have another patient with the same uh, foamy gland.
Right.
So I don't know the guy, and and he can't really tell me too much other than
No.
he's got another one that he's dealing with.
But for those of you who
You
don't,
guys should get together. Go ahead, Rick.
I was just going to say, for those of you who haven't heard, this foamy cell is a very unusual and rare type of prostate cancer. I, to be honest, know very little about it other than Richard Kramer has it, and we've been following him for a while. I mean, I don't know the ins and outs of foamy cell. I don't know if anyone else on the call does.
Well, right now, looking up the documentation, China Institute of what I'm not sure what the name is had a study of 50. Dr. Epstein published that they had 21 cases they had found total and documented at Johns Hopkins.
Mm-hmm.
And no one in Virginia, other than the two of us now, have been treated that we know of. So as long as it's working, and I'm still going.
If it ain't broke, don't fix it, right,
Okay,
Richard?
good for you, Richard.
That's
Is
about it. So anyway, I've been very happy with all
right.
the test results that just
Daniel's
come in the last month. So that's all I had.
We're happy for you too.
Thank.
Okay. How about Daniel Stroud? Is he still with us?
Yeah, I am.
Yes.
Yeah,
Daniel?
I learned so much
There he is.
last time. Are you guys hearing me?
Yes.
Yep.
Great. I emailed my urologist and my primary asking for the PSMA PET scan and received bird chirpings. So I canceled my surgery, which was this Thursday, and it was rescheduled for August, which has taken the monkey off my back immediately. So I get more information from this group and another group, and doing significant reading and watching videos. So I'm in the learning curve, very early learning curve, and learning so much. But instead of proceeding blindly right into surgery, I'm learning so much from this group that I got to pause for a minute and get that PSMA test and do another PSA test to see how my reading is for the last 6 months. That's all I have to report.
So a couple of questions. If you need it in your situation with your numbers, we can give you the references from the AUA that a PSMA test is appropriate if Kaiser is busting your chops. It sort of concerns me personally a little bit that they're willing to postpone your surgery, but there are bird chirpings around your request for a PSMA test.
Well, let me explain. The bird chirpings is that when I emailed my urologist, the nurse immediately replied, he won't be back until the end of next week. Well, if the surgery's at 5:30 in the morning on Thursday, it told me that either he's going to come flying back in here at 3 in the morning, or he doesn't want to deal with it right now.
Okay,
Rather have me on the table.
that's for sure. That's
I
for
saw
sure.
I saw a study once where they looked at the outcome of surgeons relative to when they went on vacation. And the idea was that, maybe they went on vacation, they came back relaxed and not stressed, and their surgery outcomes were better. Well, it was exactly the opposite.
Right. I also,
So,
I
Dr.
also,
John, is your advice then to make sure you don't get operated on for at least 3 days after the surgeon comes back?
Yes. Yep.
check their schedule. I also emailed my primary and indicated while we're waiting for the urologist to come back, I'd like to have another PSA test. And Friday, he emailed back that he'll be discussing this with the urologist. I have not heard anything back yet.
Be prepared for the Royal KP runaround. Okay. Now, Jim Marshall, both I and Jim Marshall have been somewhat successful in moving them off the diamond. There's probably other people here too, but I know for a fact I was, and I know for a fact Jim Marshall is.
Yeah.
And you have to be your own best advocate. I think that if you point out to them, if they give you any pushback, then let's just say this. If they give you any pushback on the PSMA, come back to us, we'll support you, because we don't want to get ahead of ourselves. They may say, yes, absolutely, you're entitled, and they'll schedule it. But I do think the other thing I would be doing right now is scheduling an appointment with a radiation oncologist in the Kaiser system.
All right. Thank you.
Because if nothing else, you want to hear from a radiation oncologist, and you want to hear from a surgeon, and then if you don't like what you hear, you want to get second opinions.
Doesn't that recommendation have to come from the primary or from the urologist?
No, you can request it. If you were scheduled for surgery, frankly, your urologist should have scheduled you for a consult with a radiation oncologist, or at least discuss the radiation oncology options with you and given you the option. That they didn't is really not right.
Right. Thank you.
Jim.
Actually, out there, I don't ask, I tell them. Schedule me for this. I need a second PSA test in the month. Make it happen. And surprisingly, it always does.
Thanks, Jim.
Eric, you had your hand raised for a while there. Did you want to comment?
Well, yeah. I was gonna say, he was saying he was having trouble, I guess, getting another PSA from your primary physician. I think that was weird and odd, because my primary physician, through my oncologist, my primary physician, it was never like an issue. I get multiple PSAs done, so I'm surprised that he would even hesitate to run your blood work. It doesn't. It's staggering. But I'm sorry.
Welcome to Kaiser Permanente. Have a nice day.
It is called turf issues. You got turned over to the urologist, and therefore the urologist's turf is that, and the primary care is now subservient to them.
Right, secondary or tertiary.
Have you had a baseline, like a complete blood work for your appointments?
Last week I reported on my PSA recordings and where they've gone in terms of the graph. The last reading was, I think, maybe 4 months ago. It was 15.5.
Yeah, but have you had like a complete blood work? Well, like all,
Oh
like,
yeah.
okay.
Oh yeah.
Okay.
Oh yeah.
So let's hear from another Kaiser Permanente patient, except I must tell you, Matt, that Virginia Kaiser Permanente is not the same as Northern California, or for that matter, Southern California. But please go ahead, Matt.
I mean, mine was just short in that one, I'm always trying to put out the positive energy. Did I get it back from these people? You know, I think that's a big part of it. Make them my absolute
Yes.
friend until they're not. But out of these groups, which group I forget, and whoever recommended it, I forget. But thank you. Somebody knew I was getting my first Lupron shot last week, starting my ADT, and they said, "Hey, you should you know, you shouldn't do it. You should have them pause it until they can do a testosterone baseline." And I literally just when I went in for my infusion therapy for my melanoma, which this same appointment I got my shot, I brought it up to the nurse manager, and they were all extremely friendly, and they went and talked for sent one email or called somebody, and they drew the blood right on my port, and they did it for me. So sometimes it goes your way in Kaiser.
It goes your way, I think, just like Jim said, or I said, and I say, you've got to advocate for yourself.
Yeah, absolutely. Yeah, that's
And
definitely.
I mean, they should have taken a baseline. They know that they should have taken a baseline, but they don't do it. Now, it's easy when they know they should have done it and they didn't do it, and the patient asks for it. The problem is that in Dan's case, he wants a PSMA scan, and that's an expensive procedure. It's not just a PSA test. So we don't know how they're going to respond to that. But what we do know is that I get them confused. I think it was the Osprey trial recommended that for men with high risk prostate cancer, they should have a PSMA scan before they do surgery.
Yes.
And if they don't know that, then we'll show them where it says it in the guidelines. But I hear you, Matt, and yes, sometimes you get no pushback, but other times you have to go to the wall with them. So we're hoping for you, Mr. M, that they won't push back when you ask to see Dr. Hartstock. That's what we're hoping for.
I mean, so if if they do a PMSA and they see that the prostate cancer has spread a little outside of the region, like
Yeah,
wouldn't that affect the decision to probably do maybe surgery or maybe not?
very much so. And
Yeah.
and, and in
Okay.
fact, that's what's come out of this Osprey trial and the follow-up to the Osprey trial, that when you do these PSMA scans pre-treatment, it can significantly change treatment decisions.
Right.
And so you're exact. Eric, I can't remember. Were you originally Kaiser Permanente in Virginia too? I can't remember.
No.
No, you weren't. Okay. But yes, that you got it. That's exactly the reason why Dan should be entitled to a PSMA scan, because it can change the treatment decision.
And actually, that's why this group is so valuable, because in addition to meeting for the first time last Thursday, I've had follow-up communication with Jim, along with a lot of videos that I've read. And all of a sudden, within less than a week, I'm on top of it, that it's not just a decision between radiation or surgery now. It's really necessary to do the PSMA PET scan now
Right.
before the decision is made.
That's right. That's
Okay,
right.
so I'd like to move on to Steve Schuler. He's our last, as far as I know, our last guy requesting time. Go ahead, Steve.
Yeah. So I guess I just have a status update. I had engaged with a bunch of you on the subject of estradiol and Dr. Wassersug, and there's actually a video that AnCan recorded that I was on. At any rate, though, so I've been on the estradiol patch for the last 3 weeks, and my hot flashes have gone from about 10 or more pretty intense hot flashes a day and a few night sweats a night, down to, it hasn't gone away completely. I'm on the lowest dose patch, but it's gone down to, today there's only been one hot flash, a very mild one, and I didn't sweat at all last night. So not completely gone, but almost gone. I'm sleeping better. I feel like I have more energy. I'm not sure whether that's just because I'm sleeping better, and I am sleeping better, but maybe there's an effect hormonally as well. But so far it's gone pretty well, but only 3 weeks into it though. So I think, I've decided I took it at like 1 month at a time from the prescription. I'm going to renew the low dose and go for another month at that low dose. If it doesn't completely get rid of the hot flashes at 2 months out, then I'll probably try bumping up to the next higher dose. But anyway, so that's where I am. I think it's so far it's looking like a very positive thing.
And
So
what else are
one
you
thing,
taking?
go ahead.
What other drugs are you taking?
Oh,
Steve?
I'm on I'm on Lupron and abiraterone and prednisone.
Okay.
Also, I'm also on Zometa for bone.
Right.
So
Rick,
yeah,
go
one
ahead.
thing I just would like to bring up apropos, I don't want to wake up Russell, but because I see his eyes are like dropping there. I can see. But Russell, you want to talk about Veozah?
Well, it was an interesting thing. The wife dug it up somewhere, and just out of curiosity or timing, my next day was with my GP. And I've asked everybody in the world because hot flashes, I can soak 6 shirts in an afternoon. I sweat that bad with them. So I talked to the GP and he goes, he said, my rep was in here just the other day. So he gave me a month's sample of a product called Veozah, Veozah, which is a new product out for women only. It is specifically designed to deal with hot flashes. It doesn't deal on the hormonal side. It deals with the hypothalamus and basically tells the brain, don't do that. So the brain doesn't do that and you don't get hot flashes. My GP gave me some samples. It works for me. The problem I have is I can get a prescription for it, but I can't get the prescription filled in Florida because I'm the wrong sex. So we were going to play a game and work around where my wife was going to get the prescription and I would take it, which is a little tongue in cheek. But the problem is this thing is not on my pill program and it's over $700 a month for the pills. Say again?
Yeah, for me the that's expensive. I mean, for me the patch, as it turns out, it is covered under my plan. It's covered as tier 3, which has a copay, and the copay is more than the price of the drug by just a little bit. So I'm just paying for it, but it's like just under it's like $42 a month or something like that.
Yeah. It's a far cry from
Yeah.
$750. How do you spell that drug? The patch.
Estradiol. I'll put it in the chat window. Estradiol. And it's an estrogen patch.
Is this something new?
No, it's been around. It's been around forever, and I would recommend if you go to our website and scroll down the homepage, you'll find a webinar, a session we just did with Dr. Wasasug and Steve and Al Latimer where we discussed it.
It's interesting because I've never heard it on this program, and all of the other doctors, including Dr. E, never mention it.
Well, Dr.
We
E
talk about it
doesn't.
a lot.
Pardon me?
Oh, yeah, go ahead, Len.
I was just going to say, we talk about estradiol quite a bit here,
Yeah, we do.
especially recently.
We've been
I
talking.
missed it.
We talk about estrogen and estrogen. We may call it estrogen instead of estradiol, but it's basically the same thing. And Dr. E is not a big fan. Al Latimer. Al Latimer raised it with her because Al Latimer is on total estrogen therapy, not just a patch for hot flashes. And she's not a big fan of estrogen for men. But so if you raise it with her, don't expect you'll get knocked. She'll take it. You'll probably get knocked down, but it's been around a long, long time. Listen to, like I say, listen. I'll put the webinar in the chat window right now. Listen to this webinar, and because Al talks about speaking to Dr. E about it, so that'll help you.
Okay.
Dr. Jeff.
There's the webinar. Dr.
Yes.
Jeff.
So estrogen, topical estrogen is not without potential side effects that you have to obviously be aware of. One is gynecomastia,
right?
Breast tissue grows, and the other is fat gain. So, we all battle fat, waist
I already
fat.
have them. I've already outgrown my training bra. I mean, come on.
They can be bigger, but we had a conversation before about gaining weight, especially if you're on ADT and abiraterone, and estrogen can even make that worse. So it's a trade-off sometimes between side effects, hot flashes, and the other things in the negative column.
Yeah.
Yeah, my hope is that by kind of titrating it, and like I said, I'm on the smallest patch right now, that I can make that less likely. But I've read the patch study, and if you look at those webinars that Rick is sending out, they reference that study, and there's some other studies by some of the same people. Author Russell and Grossman, but there's not very good data on the dosage where you might run the risk of gynecomastia more. So I mean, I'm just going with the theory that less is better in this case. So I'm just kind of titrating at the lowest dose now, and hopefully that gets rid of the hot flashes completely. I think actually where it is right now with I said, I had one today, mild. I could live with it at this dose. So even if I don't get rid of it completely, I might just stay at this dose.
I think if it were me, Steve, I would take one shot of radiation, or at the most two to my chest, because that does seem to kill it off. And I've spoken with cardiologists who consider that to be perfectly safe. And I've also spoken to enough people who didn't do it, and then they worry afterwards about the effects. So if it were me, that's what I would do, prophylactically. and it's a known treatment. It's a
Yep.
well-known prophylactic treatment if men are on estrogen. I know Len wants to close up. I just want to check in with Joe Commander. Joe, did you have follow-up questions? There were thoughts that you might have had some follow-up questions you didn't get to ask.
I did, but I'm happy to wait till next week or whenever the next time is. I'm fine with not bringing them up now. I'm not at my best at this time.
Okay. Well, let's see. Next week, I have a feeling this is going to be.
Next week will probably be.
Oh yeah, next week's fine. Dr. John's up next week, so we're here
Okay.
next week.
All right.
That's good. That's good.
Gentlemen, have a good night.
Night.
See you next week.
Good night, everybody. Thank you. Great session
Thank
today.
you,
Good
everybody.
night. Thank you. Thank you.
Thank you.
All right.